Dr. DiChiro, it's a privilege for me to come here and talk to you today at the Clinical Center at NIH, where you have been Chief of Neuroimaging for as long as I can remember in the Department of Diagnostic Radiology. We're going to talk about neuroradiology, and today in the world your name is quite synonymous with that. Your career spans the beginning and its present day to the present day, and you've been a pioneer and an innovator in this enormous field. In my hand I have your bibliography, over 300 major publications, and 5 books. Dr. DiChiro, why did you do this? How did you get into this when there was no such thing?
Well, after graduating from medical school in Italy, I was counseled to go to Sweden to receive my training in radiology. At that time, Sweden, which had been spared, of course, the ravages of war, because it had remained neutral during the Second World War, was in a privileged position in various areas, and in particular, as far as my interests go, in the radiological area. So I arrived in Sweden in 1949, and I arrived at a particular moment of development in Swedish radiology because Dr. Erik Lysholm, a famous, in fact a legendary Swedish neuroradiologist, had just died, and his successor was Professor Erik Lindgren. Now, after spending some time in general radiology at Södersjukhuset Hospital, which is the hospital of South Stockholm, after about 10 months I moved in the Department of Radiology of the Serafimerlasarettet, which was the hospital where modern neuroradiology was, in my opinion, developed. The neurosurgeon at the Serafimerlasarettet was Professor Olive Krona, who had developed his skills and his special approach to neurosurgery somewhat differently than the masters of the American neurosurgery, that is Cushing and Dandy. And he had understood right from the beginning that he had to take advantage of the skills of the individuals who were in the Department of Radiology. And also, he understood that he had to work in combination with industry. And so he cooperated quite extensively with the Shenander company that created X-ray equipment for both for Professor Lysholm and for Professor Olive Krona, and then also with companies that were specialized in producing neurosurgical instruments like the Stille and Kifa company. So in this particular center, which was the Serafimerlasarettet, there was a special relationship between the neurosurgeons and the radiologists who had just started calling themselves neuroradiologists, considered at that time the subspecialty neuroradiology did not actually exist yet. And, but the Swedes started calling themselves neuroröntgenologer, which means, of course, neuroradiologists. And it was this symbiosis between the Professor Olivecrona and later Professor Norlén and the neuroradiologist that is Professor Erik Lisholm, Professor Erik Lindgren, and later Ingmar Wickbom, Sjögren, and Greitz. And these individuals, they all work together toward the common goal of a precision in localizing the intracranial space-occupying lesions, because that was their main strength. They were concentrating in the space-occupying lesions diagnosis, particularly the tumoral diagnosis. And this, of course, was due to the preference of the neurosurgeon, Professor Olivecrona. So it was this combination of multiple strengths, a superb neurosurgeon, dedicated radiologist that is dedicated to the neurological sciences, and industry, which was just around the corner. The factory, the Shenander factory, was just on the same road where the Serafimer Lazarettet was. And the chief of the Shenander company, Mr. Shenander, used to work in close cooperation with the radiologists. And so at that time, there was a particular need in the neuroradiological sciences was responded to by the industry in creating a new type of equipment. Incidentally, this legacy of building the equipment that fits better your own purposes has remained with me, and because here at the NIH we have built a number of new imaging devices, as for instance the Tetra scanner, the Tomo scanner, the device for axial transverse pneumoencephalography, and lately the NeuroPET devices. And because I have been taught since my early days in radiology that this combination with the technical aspects and industry was of critical importance. Another particular interesting aspect of the training at the Serafimer Lazarettet was that, of course, at that time, the main emphasis was on the air studies, fractional pneumoencephalography in particular, and ventriculography. But you were taught to outline, to draw the intracranial structures as they were visualized by the air that had penetrated the ventricular system or the subarachnoidal spaces. And that was part of the training at center, which spurred the young investigators to an objective analysis of the findings, particular in pneumoencephalography. And it was this being in this very productive environment that stamped me forever, and I decided to remain in this area, the area of neuroradiology, carrying out research because I enjoy doing it. That's the way I have entered. So I have a great depth toward the Swedish school, and I think that the marks that they have left in me are indelible and will have shaped and will shape until the end of my days my research activity.
When you went to Stockholm, did you intend to become a neuroradiologist or just find it there?
No, I didn't intend to. Indeed, the funds to go to Sweden, because I was just out of medical school, I had no economic funds, were given to me by a surgeon, an Italian surgeon, who wanted to start to do cardio surgery of the heart, of congenital disease of the heart. And so he supported me with some funds to go to Sweden, and he asked me to train myself in the radiology of the cardiovascular system. But I didn't find that as challenging as the central nervous system. And so, and I was also the personality of Eric Lindgren, the successor of Eric Lindholm, as I was saying, was overwhelming. At that age, when you are a young physician, the mentor, it's critical. I mean, the personality of the main your instructor, it's of critical importance that shapes your destiny in a way.
Well, you left Stockholm, and for a time you were in France and back in Italy. You organized neuroradiology, and then you spent a year in the United States.
Yeah.
Could you reflect back on your impressions at that time? What was the state of American neuroradiology?
Well, when I arrived, I chose, by the way, because of my Swedish training, I easily received both a Fulbright fellowship and a Smith and Mond fellowship, and I could choose a number of centers in the United States, but Boston was considered, I considered Boston as a sort of a mecca of the of the medical sciences. So I went to Boston, and of course I had read the masterful and genial contributions, particularly the Walter Dandy contributions who had initiated, as we all know, the pneumoencephalography, the ventriculography, and indeed even the pneumomyelography, the air myelography. So I also, the book by Davidoff and Dyke on pneumoencephalography was considered quite important. So when I arrived in Boston and I saw the status of neuroradiology in Boston, and not only Boston, I assume was in the entire country, the entire USA, I was surprised, and I must say not very favorably so, and I really there was a barrier between me and the neurosurgeons who were there because we talked a different language. The neurosurgeons controlled totally the neuroradiological procedure. Indeed, they carried them out, they interpreted them, they barely or not at all read the reports by the radiologist. In fact, paradoxically, the radiologist wrote their reports after being instructed by the neurosurgeons. And the residents, particularly the residents in neurosurgery, were the ones who led the scene. However, I also realized that this country had they had a tremendous capability of moving and improving rapidly. One example, it's very instructive. In Sweden, when I started my training, and everybody in the 40s, when they started their training in radiology, had to spend 6 weeks in the dark room to learn the dark room technology. So in Boston, in the Department of Radiology, I was complaining that the radiologists, they really did not appreciate the subtlety of the technique that one has to apply in the dark room. But the Americans, you see, they approached in a very straightforward manner. They eliminated the dark room by the automatic processing, which was introduced indeed in 1954. So, in other words, that I realized that in this country things may evolve very rapidly, and the neurosurgeons who had been so treating the radiologist as essentially as a second level co-workers. I mean, I don't know if they considered them at the very same level of their skill, but they soon realized that perhaps it was better for them to help and assist the creation of a subspecialty, the subspecialty of neuroradiology, which in this country I feel strongly was born under the sponsorship of the neurosurgeons who had vision enough to understand that you yourself, Dr. Luessenhop, who have made some very original contributions related, in fact, closely related to neuroradiology, and of course the embolization it comes first to our mind when we hear the name Luessenhop, but you have not been hesitant to cooperate with the radiologist, and you have not tried to keep the turf for yourself. And this, I must say, has been the trend among most of the American neurosurgeons, or perhaps I should say most of the academic American neurosurgeons. And so I have to hasten to say that today American neuroradiology is second to none, and but that's 35 years later. And but in the early 50s, when I arrived in Boston, very frankly, I was shocked by the level, or the lack of technical sophistication.
Dr. DiChiro, when you say American neuroradiology is now second to none, I believe to a large measure that was due to people like you. I noticed you came finally to the United States permanently in 1958 and became chief of neuroradiology here at the NIH. Before that, you were in Italy, in Naples, where you organized and developed a department of neuroradiology at the Neurological Institute there. During these years, particularly since coming to the United States, what have been your most important contributions?
Yes, incidentally, while I was in Italy, I would like to point out that I demonstrated by selective arteriography of the spinal cord the very first tumor of the spinal cord in hemangioblastoma in the cervical area. And that was a sort of a beau geste at that time, because the department I had built in Italy was quite small, but we carried out quite good arteriography, and so that, by the way, was started my keen interest in the assessment of the spinal cord. But when I came to this country, I was, by the way, recruited by a quite famous neurologist, Dr. Milton Shai, and Dr. Shai happened to have an interest. Actually, he was a sort of Renaissance man. He had many interests, but one of his interests was in radionuclide studies of the central nervous system. In addition, there were a number of groups at the National Institutes of Health who were interested in the pituitary pathology, and so the sella turcica. And in fact, probably the first contribution I made here at the NIH was the assessment of the sella turcica in the coronal plane. As you probably remember, indeed, during your training as neurosurgeon, I'm sure that you assessed the sella turcica mostly in the lateral view of the skull, that is in the sagittal plane. However, note that today the evaluation of the sella turcica and of the pituitary adenoma is made mostly in CT scans and MR images, is made mostly in the coronal plane. And in a way, that may be the result of the emphasis I give in assessing the sella turcica in the coronal plane. And then, because we had a large number of pneumoencephalography that we carried out at NIH, I concentrated on the study of the detailed anatomy of the brain with pneumoencephalographic technique associated with tomography. In addition, at about the same time, because of my interest in the CSF cavities through pneumoencephalography and my newly acquired knowledge in the area of radionuclides, together with Dr. Shai, I thought to apply the radionuclide techniques to the studies of the CSF cavities, and so we developed the radionuclide cisternography. Then we also, I also continued my research in the area of the spinal cord. In fact, if I may put in a personal touch to this interview, I, of course, in the meantime, had become paraplegic. So it was a sort of nemesis for me, and concentrating on the study of the spinal cord became a sort of a mission related to the myelopathy responsible for my paraplegia. And so in a rapid sequence, we developed here at NIH selective arteriography of the spinal cord, immediately followed by radionuclide angiography of the spinal cord, and then followed by the supine myelography. And then when the CT was introduced, by the CT myelography with water-soluble contrast media, which actually was developed at Georgetown University with in cooperation with Georgetown University, actually at Georgetown University, with which I have been associated for over 20 years, with the device, the ACTA scanner, which you sponsored. We developed the CT myelography, which it's now a standard procedure, and then the CT dynamic angiography of the spinal cord. So in a rapid succession, a number of techniques dealing with the study of the spinal canal, but particularly the spinal cord. I've never been keen in studying the disc herniation, that except perhaps for the thoracic disc herniation, and it's so these were my fundamental interest. Then later on, when the technique of positron emission tomography was described by other investigators, Dr. Rajvic and other investigators, we initiated our activity in positron emission tomography, and probably the contribution we have made in that area was that of assessing or grading the cerebral tumors on the basis of their degree of or rate of glucose utilization, and establishing prognostic criteria on the basis of positron emission tomography. These have been the line of study and research which we have
Well, it's certainly obvious that your career has been at the frontier, the investigative side, the innovation, the creation in your field. What is your philosophy about that?
Well, the approach to a particular problem, incidentally, all my activity has always been connected pragmatically with the clinical sciences. And I have always understood that the only way to be successful in a research is cooperation with others. and not only with neurosurgeons, also who of course are the ones with whom I feel more comfortable and with whom I have always cooperated, but also with other specialty, for instance, basic scientists. And you have always, when you develop a research trend, you have to consider who are the individuals who are cooperate with you, and what are the strengths of the particular center in which you are happen to work. You certainly would not want to study disc herniation at the National Institute of Health, because we just don't deal with that type of problem. So you will have to, the research, in my opinion, has to be directed according to the strengths of the investigators that are in the same center where you are, and the strengths of the center where you happen to work.
You mentioned that your life has been association with neurosurgeons, and neuroradiology grew out of neurosurgery.
That's correct.
How do you see that relationship today? Do you see problems ahead?
Well, it's strange that you should ask that, because at the last meeting of the American Society of Neuroradiology, there was quite some concern about possible conflicts that may arise in regard, in particular, to interventional neuroradiology, of which of course you are one of the fathers. And there is now, I can see that is shaping up a turf battle in regard to the interventional neuroradiology, with neurosurgeon invading the territory of the neuroradiologists, or vice versa. Obviously, I feel that the neuroradiologists, they really are not fully equipped to take care of the patients, the entire patient. And I am a little bit of a maverick in this respect compared to my colleagues, who may be quite sanguine about keeping the interventional procedures in the realm of neuroradiology. I don't feel that way, and I feel that if a battle will develop, that will only be hurt, create harm, rather than being beneficiary. I feel that there is a need, and I hope that it will be possible to continue in a cooperative spirit, rather than creating antagonisms that in the final analysis may only be deleterious to the treatment of the patients, which is of course our final goal.
Dr. DiChiro, what are your future plans?
Well, there are a variety of projects that I am particularly interested in developing. Functional imaging is one of the aspects that I would like to develop, and that is image of function of the various segments of the central nervous system and the various the various centers. Now, of course, the two techniques that lend themselves for exquisitely to this purpose are positron emission tomography and nuclear, possibly, that has not been proven yet, nuclear magnetic resonance spectroscopy. And I am involved in both of these techniques. And then, of course, I have also hopes that through nuclear magnetic resonance imaging, we will be able in the future to visualize the spinal cord vessels, at least the dilated spinal cord vessels, if not the small normal vessels, because selective arteriography of the spinal cord remains a somewhat a procedure that must not be taken lightly, and if we could obtain similar information with non-invasive procedure, that would represent a great step forward. So I have a full plate for my future research years.
Well, thank you, Dr. DiChiro, for this very informative interview. I'm sure that your future plans will be realized, and I will follow your accomplishments.
Thank you very much, Dr. Luessenhop. It was very kind of you, and I enjoyed very much this conversation, as I enjoy my cooperation with you in other aspects of our activities.